Hey, welcome back to Not So Complicated, and today we'll be talking about vasculitis, its types, pathophysiology, clinical picture, diagnosis, and management, right? So let's begin without further delay. So, talking about the overview of the vasculitis, it is an inflammation of blood vessel walls driven by immune-mediated damage, right? So the mechanisms are immune complex deposition, autoantibodies like ANC or T cell activation. We'll be talking about that in detail later, right? So, and this will lead to the vessel narrowing, thrombosis, or rupture causing ischemia or hemorrhage. So, talking about the overview, the classification is based on the size of vessels, right? So, it is dependent on large to medium sized artery or small sized artery, arterial, capillary, venule, vein, right? So, let's talk about the types of vasculitis in details. I have already said that the basis is the size of vessel. So, in large vessel, there can be Takayasu. Takayasu is a type of vasculitis and it is most commonly affecting young women, and the pulselessness is the feature of Takayasu arteritis. And then large vessel, also there is giant cell arteritis. The most common artery involved in giant cell arteritis is a temporal artery, and it will lead to the headache, and it is affecting elderly. The other one is medium vessel vasculitis, right? And out of them, the first one is polyarteritis nodosa. It is vulnerable, like the people with hepatitis B virus infection are vulnerable to polyarteritis nodosa, and also aneurysms are the typical features of polyarteritis nodosa. And in Kawasaki, K for Kawasaki, K for kids, it is seen in kids and coronary arteries actually. And talking about the small vessel vasculitis, there can be ANCA associated vasculitis, just like GPA, MPA, EGPA. We'll be talking about this later in full form, right? And also, it can be immune complex. That can be Snollen purpura or cryoglobulinemia, right? So these are the types of vasculitis. Talking about the pathophysiology of the vasculitis, we have talked about that in overview. The three mechanisms are immune complex deposition first, like in Snollen purpura. It traps antigens in vessels, and then it activates, like the trapped antigens will activate complement and neutrophils releasing cytokines like tissue necrosis factor alpha, right? So this is the one mechanism. The other mechanism is autoantibodies like ANCA. ANCA is anti-neutrophil cytoplasmic antibody in GPA. What is GPA? GPA is a type of vasculitis, right? So it is granulomatosis with polyangiitis, bind neutrophils causing degranulation and vessel damage. This is another mechanism. The other mechanism we have is T cell driven granulomas, right? As in GCA. GCA is giant cell arteritis. It infiltrates vessel walls. So the effects of these three mechanisms is narrowing or thrombosis that will lead to ischemia. If it is ischemic region in kidney, it will lead to renal failure, and it can also happen to the rupture, right? So rupture will lead to hemorrhage, example in hemoptysis. So these are the effects. The clinical features depends on the vessels affected, right? So the systemic features that are common for all vessels or vasculitis are fever, fatigue, and weight loss. So in large vessel, as in Takayasu, the clinical feature is pulselessness, and in GCA is jaw claudication. Claudication is vasospasm or the constriction of vessels, right? On use, and GCA is giant cell arteritis. I have already talked about it. And in medium vessel, it can be PAN. What is PAN? PAN is polyarteritis nodosa. So mononeuritis multiplex is a clinical feature, and Kawasaki, it is rashes. And in small vessel, it is Snollen purpura. So there is palpable purpura in HSP, and in GPA, that is granulomatosis with polyangiitis, there is hemoptysis and saddle nose. You have to remember this specific point. Saddle nose is a typical feature you have to remember. So let's talk about the diagnosis. In diagnosis, we see the laboratories values, right? So ANCA values like anti-neutrophil cytoplasmic antibody. It can be cytoplasmic or perinuclear. So cytoplasmic ANCA are risen in GPA, that is granulomatosis with polyangiitis, and P or perinuclear ANCA are risen in MPA, that is microscopic polyangiitis, right? So ESR is erythrocyte sedimentation rate, or CRP is a C-reactive protein. These are acute phase reactants, right? So they are increased in GCA, that is giant cell arteritis again, and HBV, that is hepatitis B virus, is seen typically in PAN. PAN is polyarteritis nodosa. I have talked about it earlier too. So in imaging, we can do angiography to look for aneurysms. Aneurysms are typical feature of PAN and Takayasu. We have talked about it. And CT angiography can be done, or magnetic resonance angiography can also be done for large vessels, right? So we can also take biopsy. Biopsy is in vessel inflammation, GCA, GPA, granulomas. You can see the biopsy. So this is the typical feature in angiography that you can see in vasculitis, right? So this is the feature. Talking about the management of the disease in large vessel like GCA, Takahashi, you use steroids or tocilizumab, that is in GCA, and also in medium vessel you use PAN, that is steroids. In PAN you use steroids and cyclophosphamide, and Kawasaki IVIG, that is intravenous immunoglobulin, can be used. And in small vessel ANCA, like steroids, rituximab can be used, and in HSP, that is henosinol purpura, the drug of choice is methotrexate, and supportive you can do dialysis, as in renal failure can also be done. So this is the workup for vasculitis, right? So if there is a clinical suspicion for vasculitis, you can see whether it is ANCA positive or negative. If it is ANCA positive, so that can be granulomatous inflammation, or it cannot be, right? So if it is granulomatous inflammation, you have to look for if there is asthma or not. And if there is asthma, it is eosinophilic granulomatosis with polyangiitis, that is EGPA. And if there is no asthma, so that is granulomatosis with polyangiitis, right? So in granulomatosis inflammation, if there is absence of granulomatosis inflammation, so that is microscopic polyangiitis. And in ANC negative, there can be IgA deposition, that is IgA vasculitis, and it can either be cryoglobulins also, that is cryoglobulinic vasculitis, right? So summary table for vasculitis is this. You can see large or giant cell arteritis and Takahashi arteritis. Greater than 50 arteries of head is specifically temporal in giant cell arteritis, and Takahashi arteritis. Female, that is less than 40. Pulseless disease is Takahashi arteritis. And in medium, polyarteritis nodosa and Kawasaki disease, young adults well spread, less than 4 years of age, that is Kawasaki is kids, right? So K for Kawasaki, K for kids. Lymph nodes, and in small Wisner granulomatosis you can see, and Churg-Strauss syndrome, microscopic polyangiitis, and cutaneous leukocytoclastic vasculitis, right? So this is the summary table for vasculitis. So that is all about today. Thank you for staying with me, and please subscribe for more clinical polls like this. Thank you.